So the COVID world really turned us on to what most of us refer to as direct-to-consumer telehealth, reaching patients in their home. And some of you may have begun in telehealth about that time, and I'm going to take you back just a little bit because a lot of things happened before we got to that point. And as you've heard today, there's all kind of telehealth that you can do. But very narrowly, if I can limit this to what we would refer to as traditional facility telehealth, where the patient physically has to go to a community-based healthcare facility. And then the provider, well, they don't have to be in a healthcare facility. That often happened. As opposed to direct-to-consumer telehealth, which again, we didn't see much before COVID, but due to legal and regulatory changes that occurred, the patient was able to stay at home or possibly in the workplace, was able to connect to a provider from a non-healthcare facility. I
guess that's it.
Okay. So, and I want to take you back just a little bit because it certainly makes it relevant for the things that we dealt with during COVID. If you look back at history, and I don't know how many of you were doing telehealth in 1996, I hope none of you were, because it was really difficult. But that was the first video visit that I'm aware of that we did in Kentucky. The medically equipped video conference device, one device on one side, was $80,000. And if you don't know the term T1 circuit, that's how you used to connect things. And it was a 1.5 megabit connection, which most of us could have gotten through a phone line a few years later. But that line cost $1,500 to $10,000 a month. Oh, and there was no provider reimbursement. It was a terrible business model. But you had to start somewhere, and it's really intriguing to be at this point in time to hear about the ideas and the concepts that are going on today and other things that you will hear the rest of the day. It had to start somewhere. And for those of you that weren't around at the time, that's where it started. The Medicare rules prior to COVID, so prior to 2020, the patient must be in approved originating site, which was a healthcare facility. They had to be rural. And there was a facility fee of about $25 that was approved for that. The payment went to, and think of the term distant site provider. Distant site means the clinician, which we often would think of, well, that would be at the larger medical center. The patient was at the originating site. And Medicare had very limited CPT codes. They had very limited providers, physicians, nurse practitioners, and not a whole lot else. FQHCs and RHCs could not be a distant site. The provider at an FQHC or an RHC could not do a Medicare-approved telehealth visit. And it all required interactive video conference technology. So what happened in 2020? And while I kind of made up that chart, it's representative of what actually happened. The telehealth utilization went up 600% to 700% in a short period of time. And it's easy to look at that and go, well, that's because patients woke up, and you know, it's only been 5 years ago, but it's hard for some people to remember I certainly remember it. We were terrified of COVID. We didn't know what it was. And the idea of going to a hospital or a clinic for health care, well, that's where all the sick people are, and that's where the people that have COVID are. And so people were really reticent to go for just a medical visit that they normally would have gone, much less go to the emergency room for some reason. So the rules, and it was about the middle of 2020, the legal and regulatory agencies that manage all this really was struggling to how do we formally pass rules and regulations to free this up. But essentially they said, we give up, just take care of people. I mean, there are people that are not accessing health care. And so the idea that a Medicare patient had to go to an approved originating site that was a healthcare facility and was in rural America. That's the other thing, that the Medicare rules were only going to allow people that went to a rural healthcare facility for that provider to be paid. All of that went away in mid-2020. There was payment to the distant site provider, the clinician that provided, which was still after COVID. The limited CPT codes, for the most part, went out the window, and it was this idea of just take care of patients. The eligible providers to do telehealth also kind of went out the window. Every clinician that was eligible to do a Medicare visit in a traditional face-to-face encounter was now eligible to do it through telehealth. And even the idea of interactive video conference technology, which had always been mandated, kind of went away, that you saw that there were some audio-only visits, and especially as we saw patients that lived in rural America and they tried to connect from their home computer or their smartphone and just couldn't, that the network wouldn't support it. And insurance companies began to say, well, you tried and it didn't work, and you finished it as an audio call, we will reimburse for that. And then finally, and the thing that we often forget is that prior to COVID, the idea of cross-state licensure, I mean, this has been the way it's been for licensing agencies forever. You had to be licensed in the state that the patient was located. Those rules were relaxed as well at this time. So it was an extraordinary 6 or 8 or 10 months as the rules began to become more flexible. And so again, the utilization in the United States for telehealth prior to COVID, it was almost exclusively that traditional facility-to-facility telehealth. And that was tough for a lot of people to do. But after COVID, direct-to-consumer, primarily connecting to the patient's home, began the most frequently used telehealth service, and that made up almost all of that 6 or 7-fold increase in the use of telehealth. And it was simple, and it wasn't because patients didn't want to go to the healthcare facility, which they didn't. It's because the legal and regulatory bodies changed. They said, we've got to loosen up the rules and regulations so that patients can be seen through telehealth. So who's worried about October 1st? Really? Okay. I am. And look, we live this every day, and I know for many of you guys, telehealth is this much of your job, but October 1st, as it relates to Medicare, is a real worry point, because honestly, if you'd have asked me 2 or 3 weeks ago, and I think a lot of people that live telehealth every day, I think we were cautiously optimistic that this was going to get done. Look, it still may get done before October 1st. I'm no longer cautiously optimistic. And what that means, and we're really fortunate in Kentucky because this only truly impacts Medicare for us. But what it means is that for Medicare, we will roll back to pre-COVID. And that patient in hazard that wants to see their doctor is going to physically have to leave their home and go to a healthcare facility to connect to the physician or other provider. And when I say physician, it's going to be that limited pre-COVID list of providers, which is physician, nurse practitioner, and very few other specialists. So that's a great worry for Medicare. For Medicaid and commercial health, and again, limited to Kentucky because of state legislation that was passed beginning in 2000, we were, and I say it all the time, we were the first state in the country to have Medicaid and commercial health reimbursement for telehealth based on our state legislature in 2000. So this is one of those things that we as Kentuckians can go, we were first. And not in rates of smoking or heart problems. We were first in paying our providers to see patients that were either Medicaid or commercial health plans. Medicare patients that wish to use telehealth after the first are going to have to, if nothing happens between now and then, they're going to have to get in the car and travel to a community-based healthcare facility. Patients will not be able to connect from home, and an FQHC and an RHC cannot be the distant site where the provider is located. So big changes are going to take place, unfortunately. But going back to direct-to-consumer, it's important and became important at the beginning of COVID, and it should always be part of our strategy. Again, we'll see what happens with Medicare, but certainly with Medicaid and commercial health plan, you can continue to do direct-to-consumer telehealth. Now, I also, for some of you that have never really done a lot of facility telehealth, I just want to make you aware of the complexity of some of the work that you can do. It will offer a more robust medical exam than a direct-to-consumer visit, especially for complex patients, as we've talked about in this group. A diagnostic tool such as an ENT scope, close-up cameras, derm scope, ocular camera, intraoral camera, electronic stethoscope, all the things that your provider uses when you go to the doctor, they can use through facility telehealth. And it'll enhance telehealth exams in school-based clinics, in employer-based clinics, correctional health, and specialty care clinics. You know, some of you are familiar with things that we do with you, pediatric pulmonology at King's Daughters Medical Center, or pediatric cardiology that we do with Cincinnati Children's. They're all enhanced by the technology. So, and the other thing that often we see in these is a trained patient presenter, somebody that is with the patient, that works with the provider. And in some cases, these people provide really important medical access that the patient may not understand as they talk to the provider, or that patient, the presenter looks at the patient and says, the patient doesn't get what that provider just said. I can tell sitting in the room right next to them, and they may speak up as almost a medical interpreter and help that provider speak. So again, always consider direct-to-consumer telehealth, and even if Medicare providers go away, we still can do it with Medicaid and commercial health plans. And then I would also love for you to think about how could we leverage the more complex facility telehealth.